So I sent out, so Julianne, I sent out, it's like an iterative thing. I sent out another update. Hi Sarah, how are you? I sent out another update, so it's kind of a iterative thing. So the sample size is missing from this because I had to pull all the data for Zugui to rerun it. So it's estimated it's going to probably be like 280 total. So that's why that section is missing. It will get added in the more formal protocol will get added. But so I didn't want people to think that we had missed that. It's coming.
Hey, Sarah, how are you?
I'm doing really well. Thanks for having me.
Good.
Thank you so much for joining.
Yeah, no, thank you.
Time.
I really appreciate it.
So you guys know Anne-Marie Bresch, I'm sure. Have you met Yanda Cuffey she's an epi person at UD?
I've known her before. Actually, I met her before Nemours because we were both a part of the Pride. It's like this, I forget what it stands for, but it's like basically for underrepresented persons in research. So you go to Brooklyn and it's like 2 weeks one summer and 1 week another summer. So she was like the group, I think, after mine. Not mistaken.
Yeah, she's joining, we hope. Hope she can navigate through. And Anne-Marie.
Yeah, Anne-Marie, actually, I sent her. So, Julian, you said you did send out the updated one or you didn't?
I did not. I apologize. I was off yesterday.
Oh, no, it's okay. So Anne-Marie actually has the updated grant, and she also has, I didn't want to burden people. I have the, so I have the response, even though the grant's different, I have the response from the last time too.
It's okay. We can see what people have to say.
Okay.
I think so. Dr. Davis said he's talked to you and Kate Deans, and should you get any feedback?
Yeah. So I meet again with Matt on Friday, and Kate was really helpful for the conceptual framework model. So kind of simplifying that, and then Matt is willing to review it again. What is going on here?
That's excellent.
I was trying to. I was going to share this. I might just have to. I can't see you all if I use my.
Yeah, if you
my
share.
internet. Yeah. Well, I might have to lose it because for whatever reason, my desktop here in my office is not letting me click on to Teams right now. I don't know what's going on. So I'm gonna, maybe what I'll do is, and I don't know how you guys want to do this, I can show you the conceptual model. And
so have you done these before?
I haven't done it with you guys. No.
Yeah. So what we usually do is you get a few minutes in the beginning as overview, kind of verbal explanation for what you want to do. Not long.
Okay.
And then we go, it's interactive. So we go to the reviewers.
Okay.
And you interact with each one.
Okay.
And I'm in Boston. I don't know if you guys, I don't know who knows it.
Yeah.
But I was just checking traffic over to Logan. So I'm going to have to leave a quarter of, or I'll be in danger of missing my flight back to Philly. But anyway, so we'll try to get through discussion with each of the reviewers. And then my role is usually common themes, kind of keeping things moving forward. How many written reviews do we have?
I have Sarah's written review, and then I have one from Dr. David Fidel.
Okay, so Sarah's here, so that's good.
Yes.
Okay.
So I just have the one then.
If you want to send it to me, I can work on. Is it long? I mean,
no.
Carissa will get all of it, but it's good for everybody to hear kind of what each of the people saying, and kind of, especially if there's sort of a common theme that comes up between the multiple reviewers. Oh wait, there's Dr. Brescia.
Hello, I apologize. Just got out of clinic.
No, thank you for coming.
Thank you for inviting me. I may turn off my camera while I chew my salad.
Please.
Yeah,
I can't see everybody.
I will drink tea, but I won't eat on camera. You know what I'm saying?
Yeah, it's okay. It really isn't. It's okay. Because I'm gonna share my screen, and then I'm going to lose you guys because I was trying to share it from my other computer, but it's not working. So can you see this?
Yes.
Yeah.
Okay. Okay,
Yeah, it's
perfect.
perfect.
All right, excellent.
Nice.
So, okay, so this is a PCORI proposal. It is a comparative effectiveness research study that is seeking to improve the proportion of children with a confirmed diagnosis of hypertension. Given that it's comparative effectiveness research, it is comparing two existing diagnostic strategies. One is ambulatory blood pressure monitoring, and I'll describe what that is. And the second one is home blood pressure. And the way in which we want to do this.
Oh, I'm sorry. Hey, Chris, 1 second. Yanda just joined.
Oh, okay.
Just hang on 1 second. Hey, Yanda, are you on?
Hello. Hey,
how are you?
Hello, hi. I'm sorry, I
Hi.
had a bit of trouble getting off of mute. I'm so sorry I'm running a bit late. I was
Oh,
just coming
no.
from another meeting.
No problem at all.
No
We were
problem.
literally just getting started. Thank you so much for, I feel like I haven't seen you in a while.
I know.
Yeah, Yanda. Same. You probably
Nice to
haven't.
see you all.
Yeah. So just as a quick, so Carissa will do a short verbal presentation of what the grant's about, and then we'll go through the reviewer comments. It's interactive, so you don't have to do it like a study section, which is why we don't call it a study section. So Chris will be able to ask questions, and we'll try to get everybody's in. There's a fourth review that we'll get also. But if you could do a quick, I don't know that everyone knows each other. Just do a quick introduction of yourself before you start. But right back to you, Carissa.
Okay,
Thanks.
so I'm Carissa Baker-Smith. I'm a pediatric cardiologist here at Nemours, and I do population health research as well as in basically designing interventions to improve diagnosis and treatment in largely marginalized populations. And my focus is preventive cardiology, although I also have training and expertise in heart failure transplant. And this project is related to my preventive cardiology work.
Right. So you can do a few minutes just sort of explaining what the grant's about. You had started, but then I interrupted
yes,
you. I'm sorry about that.
No problem. So I'm going to share the conceptual model, and I apologize, I can't see you all. So this is a PCORI. PCORI is Patient-Centered Outcomes Research Institute. They fund engagement studies as well as comparative effectiveness research studies. This is a comparative effectiveness research proposal. And in this, we seek to do we have two primary outcomes, two outcomes, one primary, one secondary, and then one exploratory outcome. The goal of this study is basically to compare two options for diagnosis confirmation. So hypertension diagnosis confirmation in children and adolescents. The first strategy is to use ambulatory blood pressure monitoring, you see in this sort of middle bar here, versus home blood pressure. So just to give you a little backdrop, the way in which, when 2017, when we laid out the guidelines, I was one of the lead authors for the hypertension guidelines in kids, we defined hypertension as the result of an average of 3 in-office blood pressure measurements, and then recommended confirmation of diagnosis with home blood pressure assessment using an ambulatory blood pressure monitor. Home blood pressure, using like a device you might pick up at like CVS, was not recommended at that time because we didn't have FDA cleared devices or a protocol in which to perform home blood pressure reliably. That has changed since 2017, and there are two existing guidelines: European pediatric, and then adult U.S. guidelines that do in fact recommend home blood pressure monitoring for confirmation of diagnosis. The way in which patients will be recruited into this study is through the primary care site, which we have found to be a better way in which to recruit patients, particularly those from disadvantaged backgrounds. So we'll have 10 sites, 3 health systems. The patients will be seen by their primary care provider routinely for an office visit, and that's the office-based group selection. They will undergo their routine oscillometric blood pressure assessment. And if that blood pressure is greater than or equal to the 90th percentile for those 8 to 12 years of age, this is per guideline, or greater than or equal to 120/80 millimeters of mercury for 13 to 17, then they will have their blood pressure rechecked manually in the office at that time and averaged. The patients will be excluded from further participation if the blood pressure is less than threshold, less than 90th percentile, again for the 8 to 12, or less than 120 or less than 80, and less than 80 rather for the 13 to 17, or they're in receipt of antihypertensive therapy. After that manual blood pressure, the 2 manual blood pressures are averaged. Again, this is in the same visit. If the blood pressure is greater than or equal to the 90th percentile or greater than or equal to 120/80 for the same age ranges that I described, they will be offered 1-to-1 randomization within the site. And so we have a randomization set up within REDCap, and they'll either get randomized to what we call point of care ABPM versus home blood pressure. Point of care ABPM is just how it sounds. It's the ambulatory blood pressure monitor device would be placed by the nurse in the primary care setting at that visit, so they don't have to come back. The other option is that they're randomized to home. They will receive a home blood pressure cuff and will be instructed on how to perform those home blood pressure measurements. It's a 3, 3, and 3 approach that was recently validated, and we have the reference in the proposal, where there's 3 a.m., 3 p.m. blood pressures averaged and then measured over 3 days. They'll get a barcode in which to scan to their phone, and then they get connected to a REDCap for entering those 3 measurements. We have 3 subspecialists within for the 3 health systems, and I'll mention what those health systems are, but the subspecialists, so for myself, I am assigned to the Delaware Valley. I would then get the ABPM data or the home blood pressure data and provide a report. We have a templated report. That report goes back to the primary care physician, and there's 4 possibilities. One is that the child has diagnosed with ambulatory hypertension based upon the combination of the office measurement and the home blood pressure measurement. So any office measurement greater than or equal to 95th percentile or greater than or equal to 130/80, and out of office blood pressures that are high would have ambulatory hypertension. If they have a blood pressure 90th up to the 95th or 120 up to 130, but the home blood pressures are high, then they have mass hypertension. And then the distinctions that are not associated with cardiovascular disease risk include white coat effect and normal. And white coat effect is where the blood pressure is high in the office, but the home or ambulatory blood pressure monitoring results are normal. And the normal would be those who have 90th up to 95th in the office and normal home and point of care. Our primary outcome are the proportion of children with a definitive diagnosis of hypertension. That is confirmation of the diagnosis. Secondary outcome is actually we characterize the percent with these different categories: ambulatory, masked, white coat, and normal. And then the exploratory aim, and this is where our site selection plays a role. We chose purposely sites that are within low as well as high deprivation neighborhoods. And then we chose rural, suburban, and urban sites. So we have 10 sites in total, broken up by these different distinctions with various ethnic, racial makeup, which we'll describe more fully in the proposal, including the social vulnerability index and area deprivation of those sites. And then we, based upon the feedback from one of our stakeholders, Aetna, we did include 2 other health systems. So the health systems are Nemours, Delaware, and Florida, and then CHOP, Children's Hospital Philadelphia, and Hopkins. The last thing I'll say is that the proposal was put together as per request with the input of our stakeholders. So we had a pilot study for assessing point of care ABPM. We included the perceptions and feedback from our patient, parent, primary care stakeholders, as well as Aetna. and insurer. And so that's the description.
Excellent.
Yeah.
Thanks. Excellent. So I'll just randomly pick someone, unless someone has a burning issue they'd like to bring up right away, or if anyone has a time constraint or they want to go first. All right, so Yanda, you're on my little Hollywood Squares things. You're first. Pseudo random.
Oh, I think you're on
I
mute.
think you're muted still.
Oh, I'm
There
sorry,
you
my
go.
computer's having a terrible time trying to come off of mute today. Okay, so thank you so much for sharing the overview and
Mhm.
providing the additional context around like which each of those groups look like, everyone that's going to be engaged in the process. I just wanted to ask you a question about
Mhm.
the role of the multi-site investigators and kind of
Mhm.
what you saw their role in, because when I was reading your proposal, I was looking at
Mhm.
it through the lens of kind of being focused on Delaware, but I
Yeah.
kind of wanted a little sense of how you were going to coordinate data collection with the multi-sites, like what was going to be their role, perhaps a little more clarity on that part.
Okay. Yeah. So each health system, so CHOP, Nemours, Hopkins, we have a subspecialist site lead. So the subspecialist, basically, our job is to receive the data from the primary care. So maybe what I'll do is show you. Let me just show you one thing. I can't remember if I put it in the updated version, but let me show you this. So the way in which this is, sorry. The way in which this is set up is we have, okay, maybe you can see this. So, okay. Yeah. So the way in which this works is that we have an overall study team made up of myself, our research program manager, and there'll be a parent stakeholder lead. And then across the three health systems, and then there's a subspecialist who basically reads the ambulatory or the home blood pressure monitoring data and inserts the reporting of those results to the primary care sites within their health system. So I wouldn't read for CHOP, just like Julie Brothers wouldn't read for Nemours. And Tammy Brady reads for Hopkins. And then each of the primary care sites within the health system has a site PI. So there's one pediatrician identified at each of the sites who's like the lead for that practice, and they're responsible for making sure that their site is aware of the study, that things are happening the way they're supposed to. We'll have regular meetings. I didn't yet put the schedule of the meetings in the proposal. I do apologize, but there's set meetings, more frequent to start. But the data itself uh, gets sent to the pediatrician through the electronic health record. The collection of the results goes into a red cap with a de-identified ID number. So each patient enrolled in the study will have an identification number. And so CHOP data, like I won't know who the patient is at CHOP, but Julie will. I'll still see the data, but I won't know exactly who that patient is. Like I won't have like their MRN or anything like that. So that's how we were gonna. I will have date of birth though, so we do need like date of birth, date of this, date of the visit, their ambulatory, their home blood pressure, some of their demographic, as well as their um, those sorts of data. So I guess it's de-identified to a degree. I suppose if you really search, you could, kind of figure it out. But
That's awesome. That actually answers one of my questions. So I was thinking about kind of long term as you think about writing up the findings and
Mhm.
analyzing the data. Were you planning to analyze it in aggregate, or were you interested in kind of looking at some of those nuanced differences between each of your study sites, perhaps some of the urban versus rural differences, or just like specifically looking here at the state of Delaware?
Yeah, no, thank you for that question. So initially it will be an aggregate, but one of the reasons it took me a little time to get the sample size data into the grant, that's why I'm still waiting for it, is I pulled all the references that we have to date about these different subgroups, what exists, so that when the statistician does the sample size, we'll have hopefully adequate power for some of those exploratory variables. So The exploratory variables that we're interested in are rural versus urban, although we're probably going to link rural and suburban together, and then versus urban, and then SVI, so social vulnerability index, ADI, race, ethnicity, primary language, insurance type. Are the ones. So those would be sub-analyses of the primary analysis. But the primary analysis is really comparison of confirmation of diagnosis using these two approaches. So either the point of care, ABPM, or home blood pressure. And I didn't provide this data, but just to kind of give you an idea of what that looks like. So Tammy, the reason why I selected Tammy is because she leads a lot of the studies related to home blood pressure. She's sort of the guru when it comes to oscillometric devices and home blood pressure assessment in kids. And so that's why I selected her. And so she did lead a study during COVID, admittedly during COVID, where there's only about 36% return of home blood pressure data. And then Corinna Ria is at Boston, did something similar. So the rate of return for home blood pressure is lower than point of care. Our point of care ABPM return data was 100% just by offering it at the site. So that that made it nice for the sample size. And then, but for those subgroups, we will do subgroup analysis. We probably won't be able to exclude, like the subgroup will be Nemours jointly because we only have the one Florida site. It's just they have budgets, and so we applied for a 5 million cap, and we're kind of there. So we couldn't add more Florida sites at this point. Did I answer your question? Sorry.
You did,
Okay.
absolutely. And you did include this in the updated version of the proposal. So I did see it.
Oh, you did see. Okay, good.
Yes, I
good.
did.
Yeah. And the grant itself, like I feel bad, but the grant itself, there's multiple iterations. So I think, yeah. So there's another iteration. Happy to send it along if you guys want to review it.
You have other questions, Anna? Or suggestions?
The only other question I had was about kind of the rural setting. And so that question was more about the 24 hours that they're wearing the ambulatory blood pressure monitor. So my understanding, I could be wrong, is that they'll receive the ambulatory blood pressure monitor and then they're going to return it within 24 hours. Might that be
well, yeah, they can return it. Sorry, it's not necessarily to cut you off. So we place it there. There's an hour setup, an hour takedown, so it ends up being 26. They're asked to return it after they complete the wear. We provide the read within 72 hours of return, 72 business hours of return. One of the things I didn't stress is that the return of the device. So we have study coordinators to call the families to remind them to return the device. And we've had to use them. In our pilot, we actually used both the research coordinators and the community workers. We had community workers. But the options will be FedEx, direct drop off, or they can, additionally just send it back.
Perfect. That answers my question exactly. Thank you very much.
The home blood pressures they keep. They'll keep.
Yep, I figured.
Yep.
Thank you.
Yeah, no problem. Just taking notes.
Excellent. Thank you, Yanda. That's great. Quick question, so I don't forget to ask you later.
Yeah.
Are all the DUAs and processed? Is there like the data use agreements and all of the sort of nasty stuff? I don't know when PCORI asks those questions.
Yeah.
But is that being worked out?
Yeah. So I have to say there's a lot of email exchanges, and some of the emails I like store the content in my head, and other ones I'm like quickly sign and get back. So that was some of the quickly sign and get back. So I know CHOP has a process. So I submitted all the things to Julie to make sure she had that, because they have a whole clearance. So it has to go through data use agreements, had to go through like the primary care site, then it had to go through their like IRB process. So we'll make sure, but yeah, like we've been going through those loops with them just with
Okay.
Hopkins. And
I'm sorry I have to do that, but I think it's good. It's good that you're aware of it and you started early.
Yeah, like it's interesting to see how these health systems, yeah, the difference, like CHOPS IRB is pretty, it takes a while. So yeah.
So if you need any help with that, there is a regulatory coordinator that works with my group. If you just need help.
Oh, that would be great.
Yeah, you could email mentoring@nemours.org.
Mentoring@nemours.org. Okay.
Yeah, and just say you have a multi-center trial and you need some coordination help with whatever it is, DUAs or IRBs, whatever you need.
Okay. I need assistance. Okay. Yeah, that's great because I'm not sure how much Kim knows.
She's done a lot of these. She's very good. Sarah Smart, I don't know, have you met Amelia? So Amelia Dorsey's her name. So it's great because
awesome resource.
Yeah, that's great. Yeah, I've been relying on Kim Roberts, and she's been great, but I don't know how much she knows about like multi site studies, multi-center studies. Okay.
Knowing the right questions to ask is huge. Yeah, so you send an email there and Amelia can connect with you.
Okay.
She supports CTR people. Like you're a perfect candidate for her to work with. So that's great. All right. Perfect. So thank you very much, Yanda.
Yes, thank you very much. I appreciate that.
Sarah, things got rearranged. So Sarah's next.
Sure. So this is my first time engaging one of these. So I don't know how helpful my comments will be. And I sent them to Julianne. I can forward them to you too, just so you have like kind of my written notes, but I'll ask a couple of questions. I was wondering if you could elaborate on why you might combine the rural and suburban. I know it's an exploratory aim, but it seems like rural might be really different than suburban.
I agree. I'm going to double check the RUCA scores for the different sites. It's just when I was looking through the sites and their addresses and everything and how they're broken down, I just don't think Milford is probably the most rural of the sites that we have. And one of the things you lose when we go to more rural is sample size, like the number of patients that they see. Yeah. And, it was a careful, so I've run studies and trials, but as a single site. And so one of the pieces of feedback we got from the first submission is like, oh, well, the PI hasn't run, multi-center trials before. So I hesitated to make it like 100 sites because you're like, okay, really? Like you went from 1 to 100. But bringing in Julie and bringing in Tammy, who have some experience with some increased number of sites, I thought 10 was reasonable. And then, we established relationships with Jessup, St. Francis, Milford before, and then we added TJU for a different study, and so there's experience there from a research perspective. And then like I said, reaching out to CHOP and to Hopkins to try to get at least one site high deprivation and one site low deprivation. So that's kind of how that sort of panned out. So I think more of our analysis will be around the deprivation. And I should say that when they looked at, so Corinna Ria's study from Boston, when they looked at who was more likely to complete subspecialty evaluation. So a lot of these confirmatory testing or confirmatory tests are performed by the subspecialists. And when they looked at, who was more likely to complete that referral, it was they used social vulnerability index or some sort of indication of deprivation, race, ethnicity, and so, minority populations, higher socially vulnerable populations, less likely to complete that referral. So I think from existing data that's there, I didn't see as much about rural versus urban when it comes to this particular question. But certainly when it comes to what's been published, we have some justification for, looking at that particular subgroup. But I did not want to exclude our rural group because access to the device is an issue. If they live too far away, they're just not able to get to the device. which is a different project.
Yeah, that's kind of what I was wondering. Just access wise for rural might, yeah.
Yeah, we actually, so this project, I guess to kind of give you guys, so I basically took a larger project and broke it up into 3 separate grants. So this is a comparative effectiveness of point of care and at-home blood pressure, but we just got, hopefully it'll go through the COBRE to look at resource distribution, resource allocation, based upon site distance, individual distance from sites, and who's getting resource and who's not. So that was we are looking at that in a different project. Mm-hmm.
Cool. This is all like amazing, and I think it's such an important project. A lot of the feedback that I had was more about just clarifying simple things and kind of the writing. Again, you're making multiple iterations on this, so I don't know how much of it, again, will be applicable, but I did have a question about why you chose kind of this randomized control trial versus like a pragmatic trial where you would just be talking to the families about the benefits and burdens of each and then looking to see which one might be more accurate in terms of the confirmatory diagnostics. So I don't know if you could talk to that at all.
Yeah, we went back and forth. Initially, this was designed as so the first time we did this, and I can share my screen. The first time we did this, we had more of a qualitative component to it. The aims were they were diagnostic, but they were also qualitative. So we were capturing more of the patient, provider, parent feedback about these different approaches. And the initial study was comparing point of care ABPM to the guideline directed diagnostic strategy with intervention arms. We actually had like a celebrity chef coming, and we had some interventions. It was just too much. So I don't know. I've vetted this kind of through different channels, and I think probably what did it is when I met with Matt Davis about the aims, he was like, well, what about if you did it like this? So there was like I guess less enthusiasm around the qualitative aims that I had in there. Our pilot is largely it's mixed method. So there's some quantitative and then there's heavily qualitative, and so that's where we got these interviews. But to your question, I think we can only have 3 aims, and we kind of got down to just like I said, that conceptual framework of what was the primary issue, what was it that people were most interested in from the patient, the stakeholder perspective. And I say stakeholder in terms of the parents, but also the providers. So the biggest challenge for the providers, the primary care providers, is really figuring out who has hypertension and who doesn't. And that we heard over and over again, both through the work that we did and then, others who have published in this area. There's probably now 4 papers out about the challenge that primary care providers have with regard to diagnosis. Actually, more than that when you consider the underdiagnosis. It's probably like 6 or 7, 8. But that's why we kind of settled on the primary aim of diagnosis confirmation. And then when I was looking at, so one of the things that PCORI asks is what critical gaps are you addressing in your study design? And so going back through the gap analysis that we published, we had an NIH workshop several years ago that I was a part of. And so we identified gaps in hypertension diagnosis at that point. And I tried to bring some of that in, and then we recently published in 2022 a gap analysis for ambulatory. We redid the AHA statement on ambulatory blood pressure measurement in kids, and in the bottom part of that, the last part of that manuscript, identify where some of the gaps still existed. And so, looking through those repeatedly, I also decided to focus the aims, the primary and secondary outcomes of the study on that gap analysis. So to answer your question briefly, walking back through my thought process, it was based upon the gap analysis that we sort of settled on these. Not the gap analysis are perfect though, right? Because, this idea of mixed methods and getting patient or stakeholder input and study design is a fairly newer concept for this field. So I don't know that when all of us were in the room that many people were thinking in that direction. And so,
Yeah, I think that's really helpful context. I think I was thinking about it too in the terms of like you get a kid that's diagnosed accurately, and then when you're thinking about long term, like I don't know what the recommendations are for monitoring at home. So I was kind of wondering like if ABPM is like becomes the gold standard sort of for this outpatient quick assessment, then is the home as beneficial, and will people continue to use it at home? So that's kind of what I was thinking about it.
So you got into the area that that makes this project a little challenging. So more recently, just about 10 days ago, NIH had another workshop on hypertension and adults and peds. So I'm just going to give you, stop me if it gets too long. I'm going to give you like the 2-minute challenge here. So, and I try to present this in the paper, in the proposal. The importance of hypertension is it's tied to cardiovascular disease outcomes. The ambulatory blood pressure monitor gives you a full scope, day and night. There are studies which show that the consistency of assessment of blood pressure is best performed via ambulatory blood pressure monitoring. There's additional data that would suggest that home blood pressure is better, both of those better than office. The way in which hypertension, though, is defined, and some of the larger studies that have linked hypertension in kids to poor cardiovascular disease outcomes in adults have just used office measurement. So the challenge is that we have to do this sort of thing where we say A equals B, B equals C, so A must equal C, which is we know that hypertension is associated, it's best measured with ABPM. We know that office measurement is tied to cardiovascular disease outcomes. So it must be that ABPM data outcome is tied to, and similarly home blood pressure is tied to cardiovascular disease outcomes. We have not done the longitudinal studies, the 20-year ABPM data to track it forward. That is missing. The systematic review that I put in there's a systematic review that does support the notion that it is the ABPM and the home blood pressure that is the best for predicting CVD outcomes. But that data doesn't yet exist for kids. So to your point, I think what you were getting at is sort of the long-term trajectory of these things. And I really, what I added to this proposal is what happens next. So in the report, and I'll probably include this as a supplementary, is what the report looks like. So in the report that we currently send out to the primary providers, we give them the diagnosis based upon, we pull the office measurements and we have the ABPM data. We give them the diagnosis and then we give recommendations. And the recommendations will follow something like always DASH diet. So always dietary approaches to stopping hypertension, increase fruits, vegetables. Then if they have nocturnal hypertension, we recommend a sleep study. And if there's any abnormality, we recommend referral to a subspecialist. We're probably going to leave it that way, leave it as referral to a subspecialist, which I know it's fraught with issue because, like I mentioned to you, completion of the subspecialist referral is not always there. But at least the primary care physician we've addressed the primary care physician stakeholders' concern, which is confirmation of the diagnosis, is how I've justified it.
Yeah, no, I think it makes sense. Thanks. That's really a very helpful background too.
Yeah, it's a little, I can.
Thanks, Sarah.
Yeah.
No,
there's lots of opportunities for more stuff down the line.
Yeah. Yeah, like I said, we had a whole thing before, but it was just too much. Yeah. So
it's a strength. Having a lot that you can do down the road in those trajectories is a good thing. So there's some comments. I don't know that we did you see David Fidel's comments? Carissa?
I haven't gotten. Oh, no, I don't
No,
think
not
Julian's.
yet.
Yeah,
I haven't sent them
I
yet.
think Julian can just send them. They're very straightforward. He sent an email. He wasn't able to join.
Okay.
But I'm gonna go to Anne-Marie last, and I might ask you a favor, Anne-Marie. The time is I'm in Boston. I have to catch a plane. The time it takes to get to the airport has been getting longer, so I need to go. I need to go.
Oh,
I was gonna try to make it all the way to 2, and then I told these guys quarter of, but I should, because I have to. And you've done these kinds of things before, so I'm gonna ask if you could finish with your comments and then the wrap up with Julianne, and I can touch base with Carissa. I don't know when you're around. We'll figure out a time so that we can talk.
Okay.
But it looks really good, Carissa, I must say. I know it came from something that was really big and is honed down, but I think it looks really good now.
Yeah, I have more.
Yeah. You have more. You have a little more time too.
Yeah.
So that's good.
Yeah.
But I appreciate Anne-Marie. Thank you so much.
I don't know what I'm gonna do, but have a good flight.
Yeah.
Thank you.
And would it be possible, Julianne, just to capture from people if they're willing to review the next iteration?
Yes.
Okay.
If you want me to after you hear my review. Just kidding. Okay. So hi, I'm a pediatric rheumatologist. I know no cardiology. So of course I think this is amazing because I think that it's something that needs to be answered. And I even see in my own patients with high blood pressure, like patients with lupus, that like they don't go when I refer them, they don't check them, whatever. So, but what I'm going to do is review from the point of, I've been on 2 PCORI things, 2023, 2024. I just sent you a blank one of last year's reviewers template.
Okay, thank you.
Okay, so believe it or not, these PCORI, anywhere from $5 million to $30 million, it is a much more rigorous review than even a K or an R01 that I've been on. So because a lot of the PCORIs are a lot of money, right?
They're a lot of money. Yeah.
Yeah. So literally, if you go down that critique, that template.
Yeah.
And let's say there's 7 questions under criterion 1.
Yeah.
When I send my review in, both years, they do a critique of my critique. And if the reviewer doesn't answer a question, they send it back. They're like, can you comment on question 3 under criteria 1? I'm like, oh my God. So it's really incredible. I mean, the PCORIs probably take me 10 hours to review. Don't worry. I didn't spend, but if I'm doing them as a reviewer, it takes that much time because if you leave something out, they will come back to you and say, so they don't think, oh, this will get brushed under the rug. You got to make sure you address everything so that the reviewer's like, oh yes, they did that. Yep, I found that. Yep, they're really, really rigorous and prescribed in the way they do it.
Okay.
In the study section, each grant is reviewed for about 45 minutes. Like it's a situation. Like these are nothing will get past them, honestly, is what I have found.
Okay.
So a few questions. The one was this is a broad pragmatic study. That's the ones I reviewed for before. My first question was the $5 million, the budget. I didn't know the budget. You have that critique that you have. Was that of the bigger grant?
Yes.
Okay. So then what I would do is literally anything that at all applies to what you've extracted to make this grant, I would answer like you're answering a manuscript. Like, yes, sir, can I have another? Like, it's, exactly what they said.
Yeah.
Make sure you address that because even though you'll probably get a different reviewer, they tend to come up with the same themes over and over again. So I would absolutely rigorously go to every line that applies to this thing that you've extracted as your smaller grant and make sure you answer every single one.
Okay.
And then a few things just so under your exclusion criteria, the version I have, which is what was attached to the Teams thing, says an exclusion criteria is not in receipt of renal dialysis, but the exclusion is probably receiving or
Yes.
Okay, so I changed that.
Yep.
Then I think you're going to get dinged if you haven't named your lead parent stakeholder.
Okay.
it says to be determined, and what's going to come back, the reviewer's going to say that stakeholder should have had input from the inception of this grant. So why do we not know who it is? So that's a big thing on the PCORI, is really them saying, you know what? From the little formation of this little zygote, that the parent, that all the stakeholders were engaged in writing the proposal, in planning everything all along. And so I think you better, if you can, you have a month, but I would name that stakeholder if you can.
Okay.
Because they should have been having input already. Now, on your recruitment sites, are these from the pilot or are these projected? What are these? In the beautiful figure on recruitment, you have Jessup, St. Francis, and Milford so far. But it says like screened past tense.
Oh yeah, we have 10 sites. So we have Milford, Jessup, TJU.
I know that.
Yeah, they're all a part of it.
But no, when you're on this recruitment sites, this figure?
Oh, that's going to be updated. Sorry.
Yeah. Okay.
That's old. That's from the prior. Yeah.
Okay,
So
perfect.
I'm going to update that with once I get everything from Zugui, from the statistician. So that
Great.
last figure is going to be totally reworked. Sorry about that. Yeah.
No, don't apologize.
And the tables with the numbers, all of that.
Yeah. And I would be very careful because you say things like number of potential enrollees per year is 85 and total enrollees in 4.5 years is 600. So even that doesn't add up. I would just be really careful about those numbers. And it also looks like you wrote it in the past tense, like screened, enrolled, but the date hasn't happened. So if you're redoing that, that's perfect.
Okay.
Recruitment site. You maybe just didn't include these paragraphs, but the approach to engagement.
All of that's going to change. Yeah.
Okay, fine. Be very, very careful because really the first two letters are patient-centered. Right. And so these kind of grants are not about us and what we want to do as doctors. It's about what patients think are important for their outcomes. And so I would do that, the engagement, how you're getting the stakeholders, and exactly what you mentioned. They're going to talk about the physicians, the patients, the parents, and the insurers. And if you don't have all those names, you're going to get dinged.
That's what dinged us last time. And I have they were very clear. They're like, you don't have an insurer. So I've been working with Aetna actually every other week. And then we also didn't have the larger stakeholder like AAP. So I couldn't get an AAP letter. I'm going to get local AAP. So Jonathan Miller is going to write that letter. And then we have Matt Davis said, get the lead. Even I was a lead author. We get the first lead author of the guideline to write a letter of support. So I'm going to have that too. So
that's amazing because that will feed into your dissemination plan, right? Because that's one of the ways you're going to disseminate. So that's another big topic. Like you could have a great grant, but if they don't think patients are engaged or care about it, and if they don't think it's going to go anywhere, after this, then you get a big ding. So your dissemination and implementation plan, I would just be like, we will be shouting it from the rooftops. You will be doing TikTok videos, whatever. But it's really going to get out to the stakeholders after you have the data.
Can I ask you something? Since because I've done one PCORI review just this year. But and I had Anita John come this morning for a research meeting. So she has PCORI. She has 2 PCORI grants.
Oh wow!
She had a conceptual framework for, I think it was for the engagement. I forget the names of it because these conceptual. Have you noticed that in the 2, like people have used like a dissemination framework or a engagement framework?
Yeah.
Okay.
They have lots of things like that. And they even have big leadership structures, which I think you better put a leadership structure, right? Because this is a multi-center grant, but you're the unifying PI, right?
Yeah, so I have a figure from the last one. It shows the whole, I haven't put it in this one. I should have copied it, but we have a whole thing with like it's a multi, I'll show figure.
Yeah, because they really want to see that you have a handle on coordinating all this information and the sites that they've invested the money in, right? And so, yeah, definitely any kind of figure you have that with big labels like engagement plan, leadership structure and leadership plan makes it easy for the reviewer, right? They can find it when they get, and look, as I said, look at that template. Those are the kind of things reviewers who are rushed and tired are going to go look for. If they can find it easily, then you're up in a strength. If they can't find it, it's going to be a weakness, even if it's in there. Because they can't, if they can't find it, they're going to put it, oh, she's lacking a leadership plan. So make it easy for them.
Okay, I'll make it. I have it.
And one last, statistical descriptions, did I miss them?
No, I'm waiting for, I had to send him all the poll data from the references. So I'll have all that added. Zugui is the statistician. He's working on it. So he and I have been working together for a while. I just had to give him the numbers from the literature. So he has that.
Okay, perfect. So, yeah, I would get a lot in there because if they think that you can't analyze your data.
Oh yeah, no, it'll be very detailed.
Yeah, okay, good.
Yeah.
And then my last little comment would be, and I think we've said it all along, they really want to see that all of these stakeholders were involved all along. Can you say that truthfully? Or in the last 6 months, we started our parent council, or in the last year, there was input sought from so-and-so in the writing of the proposal. Can you get a nice paragraph like that? That's truthful?
Yeah. So we basically, I have to say, the first time we put this together last winter, we had the parent stakeholder calls. So I took all that data. We have transcripts from it. And then more recently, we've just continued to collect because of the pilot.
Yeah.
It's a qualitative component. So I have all their quotes and their input. So it's been over like almost a year and a half now.
Yeah.
Where we've been, and just more recently, we've had better engagement with the insurer stakeholders. So that input I have too. So I'll incorporate all of that. And I have direct quotes, and those are taken from but we have, I guess, 40
I like the
pages
little quotes you put in there.
Yeah.
They were good. But it's going to sound dumb, but definitely a little bit beat them over the head with stuff. Like, here is how our stakeholders, like a sentence that sounds too simplistic to you.
Okay.
But be like, this is how they've been engaged for the past 18 months or whatever, as opposed to if it's buried in a paragraph, oh, the parents said this. Then later, if they're like, well, weren't the parents engaged? They're not going to be like, oh yeah, there was that quote. You have to spell out hand it to them that we have engaged so-and-so, so-and-so, and so-and-so in the inception, in the measurements, whatever they were engaged in.
Okay. Yep. We have that. Yep.
Otherwise, I love it. But I'm just thinking.
I have to clean it up. Yeah, I definitely have to clean up because I know Yanela made some of the similar comments, just wanting to know how all the data was coming together, especially since we have these 3 health systems.
Well, but I think that's a real strength, right? You've made sure that you have all different areas, all different types of practices, so that you can do your exploratory aim, which is fascinating. But you haven't relied on that aim, right? You have aim 1 and aim 2, and then those are very kind of cut and dry. And then exploratory aim. Do you think you'll be powered for the exploratory aim because there's so many different variables?
He's working on that now, so we're going to look at it. So I sent him all the numbers that I have from the literature. So what I'm probably going to do is simplify the exploratory aim. I know that SVI, like Social Vulnerability Index, race, ethnicity, primary language, probably are going to be okay. ADI, I'm probably going to have to take out, and then like Sarah and I were talking about, I might have to take out. Well, I was going to combine rural with suburban, so we say urban. Maybe I'll say urban and non-urban. I don't know if that's going to fly, but apparently there's this ex-urban too, by the way. I don't even know what somebody presented that at AHA. It's ex-urban. I don't know what anyway,
like but urban sprawl, like you move out.
I think it's like you move out of the urban area, but it's not rural. I don't know. Do you know that term, Yandel? That was the first time I heard it. Ex-urban. Anyway,
I've never heard of that before.
Yeah, I'll ask Anita again because it was her group that or Cincinnati's group that presented exurban.
Yeah,
but
I was like, I used to live in a city and now I don't, but my asthma got better. I don't know.
But it has to do with like you're not the way I pictured it, it was like you're in a rural environment. It's like when you drive out to rural environments, you see like that $10 million house. Like it's not really like, you know what you know what I mean? Like you're not really disconnected.
Oh yeah, you're right. It's okay. Here's the I Googled it. A district outside a city, especially a prosperous area beyond the suburbs.
Yeah, that's the
and they also
picture I
call
got
them
in my head.
exurbs.
Yeah, that's the picture I got in my head. I was
that's
like,
awesome.
okay,
Exurban.
yeah, exurban. So like, because if you say rural, people picture rural, right? But you go to some of these rural communities, it's like Leesburg, like that's rural, but like, I mean, I don't know if you guys have been to Leesburg, but like it's pretty.
But I think it's an absolutely wonderful question to answer. And I think it has real implementations. I don't know. It will
implementable.
I'm losing it today. I'm like running around. But
no,
I think long term, this will have a real impact on patients and patient care. Now, one thing, that other critique, I only got through half those slides.
Yeah.
But someone cranky wrote like,
first reviewer.
There's nothing that says your blood pressure as a kid has anything to do with your cardiovascular outcome. Do you remember that one? I'm probably
that's reviewer. Nope, that's reviewer one. The science reviewer was, I think, just curmudgeon. Like it was just.
Well, obviously an adult doc.
Obviously, yeah. I think adult.
We lost someone.
Yeah. I think we.
So, do you have articles?
I do.
Good.
I do.
And you don't want someone else saying that.
I tried to like when I rewrote this, I tried to make it clear over and over again in multiple different places, the same, that it tracks, that we have the data that shows that it ties is associated with greater odds when it presents in childhood. Because they didn't like, I saw the sentence, but I made it clear in this grant is when it's present in childhood, it is associated with adverse cardiovascular events in adulthood.
That's perfect, because no one else missed the critical gap or the significance of your study, but then they just wrote that one cranky thing.
Mm-hmm. Everybody else got it. It was the scientific reviewer
that sucks.
Yeah.
Okay, that's all I have. Do you need me to...
yeah, go ahead. I was going to ask you.
Do you need me to send notes, or you got what I said?
No, I have what you said. I guess what I'm going to ask is like, maybe I can coordinate with Julianne. I know there's a bunch of stuff I still need to add. I'm going to meet with Matt on Friday because I wanted to get the critiques from everybody from today. I guess my last questions are: people comfortable with the aims? Because I do need to reach out to PROCOR. I did change a couple of things, and they're very specific. Like if you make any changes, they want to know. So I was going to make sure that. So the aim one is to compare the proportion of children and adolescents who complete hypertension diagnosis confirmation testing following receipt of point of care ABPM versus home blood pressure.
I have I'm sorry, were you still going?
No.
I have the written feedback from David Fidel, and he I'm just looking through his, and it looks like regarding AIM-1, he wrote, I did not understand the hypothesis for AIM-1. Are you hypothesizing a null difference?
Yeah. That's a good question. Probably, I always believe with the hypothesis testing, it's easier to test when you assume the null hypothesis to be true. It's like, there's no difference, right? So that would be yes. And we can rewrite it that there's no difference. Although the justification for the aim is that we found that there is. So I don't know if that's confusing to people. Here I wrote, we hypothesized that point of care is associated with more children and adolescents who complete hypertension diagnosis confirmation than home blood pressure. And that's just based upon the data that we have published.
Is the home blood pressure the current standard of care?
No, what standard is office followed by ABPM with a referral to a subspecialist. So we know that subspecialist referral doesn't happen largely. So we're taking that piece out. We're saying, well, what about if we just compare point of care ABPM to home? And I justify it by saying the pediatricians are using home blood pressure. They're recommending it. And I justify it by saying when we put the guidelines together in 2017, we didn't have any protocols or FDA cleared devices for kids, but we have those now. So it really does warrant comparing, because now you have a different way of providing ABPM, which takes out the referral piece that we know drops off. And now we know we have protocol and device available for home blood pressure. So that's how I rewrote this is the draft I sent you, Anne Marie, yesterday, day before yesterday. In that first paragraph, that's how I justified this study.
I wondered too if you could add, I don't know, maybe you need more literature to support it, but on the home blood pressure monitoring, I mean, in terms of like them having to do it, following all the guidelines to do it, and that it's repeated over 3 days versus the 72 hours, I think also increases the likelihood that it would be less effective or less complied with, maybe.
Yeah. I have some quotes to your point too, I have some quotes from one of my patients who's like, well, I like the ABPM better because I can go to work and it can check my blood pressure. I don't have to stop, and because I can't, he's like, I work at McDonald's and I can't stop and check my blood pressure at work, So, yeah. So, it's funny because 7 days is reduced from, 3 days is reduced from 7. It used to be 7 days. So I incorporated that reference. Yeah. So I guess, yes, and I can add that for sure. But I guess my question is, do the aims make sense to people? These are the main two. It's to compare the proportion who complete that diagnosis confirmation. Kate didn't like the confirmation word, but I had to keep it in because I wasn't sure who was going to review it. And it really isn't diagnosis per se. I went through this with Dr. Flynn because he's the lead author on the guideline. It's really confirmation of the diagnosis, because the way we define it in the guideline is the 3 office measurements, even though there's quite a bit of white coat effect.
I actually had that question and I was reading it too, because it does read a little bit confusing. I was wondering about maybe just putting like, when you have hypertension diagnosis confirmation, if you can just move confirmation to hypertension diagnosis or, in front of, so that it like.
Who complete confirmation of hypertension diagnosis?
Yeah, because it looks like, oh, we got more people with hypertension. Isn't that great? But because the diagnosis got confirmed, yay. No, you want the diagnosis to be accurate.
Yeah.
Yeah, but that might mean that it's not confirmed.
Complete confirmatory hypertension diagnostic testing.
I like that.
Who complete what? Confirmatory?
Confirmatory, yeah.
Yeah, exactly.
Confirmatory.
Okay, I am sorry. I have to be on another meeting for which I'm an hour late for, which is fine. Oh. They knew. No, they knew I was going to be late, but I have to join now. So thank you so much, Carissa, for letting me. I know it's hard to send things out and hear people critique it, but thank you so much for letting me review it. And again, I don't know any cardiology. You're welcome. But if you want me to review it again, I'm totally happy to.
Thank you. I appreciate that. Yes,
thank you.
Thank you, Dr. Brescia.
Say anything Rob thought I should say as a wrap up, because I don't know. You do that. Okay.
This was excellent. Thank you very much. We look forward to seeing you next time.
Thanks for the opportunity, and I can follow up too, or I'm happy to read again if it's helpful.
Thank you. So. Yeah, no, I appreciate it. I really do appreciate you guys taking the time to do this, because it is helpful, because you don't see what you don't see. You know what I mean? Yeah. So thank you very much.
Great job.
Thank you. Thank you.
Bye.
Thank you.
All right, take care.